Hello, my name's Ashleigh Mitchell. I'm a specialist paediatric dietitian. So my background is that I've worked at the Children's Hospital Westmead since 2011, primarily with children with genetic conditions. And I've recently opened a private practice in Menai and telehealth. And today we'll be talking about nutrition tips for children with Mito. So for background, we're going to go through understanding Mito, the role of the condition, and what we do in clinic to set some goals to support families. So for background, to understand Mito, we need to know that the body is made up of cells, and the cells contain the mitochondria. So the mitochondria is like our energy powerhouse of the cell, and it's where food is converted to chemical energy. So in Mito, the mitochondria, or our powerhouse, can't efficiently turn carbohydrate foods into oxygen, and oxygen, into energy, which can cause the cells to malfunction. So any bodily organ can be disrupted. So there are many types of Mito. It can present at any age with any symptoms. And so how one child is affected by Mito is quite different to how another child may be affected. So this makes it really hard to work out what the best treatment or nutrition is for children with Mito. So there isn't really an optimal diet or clear consensus, and we aim to individualize nutrition tips for each child. So treatment goals usually focus on symptom management and providing supportive care. So why is nutrition important? We know that nutrition plays a role in chronic conditions, particularly for children. So we know that poor nutritional status results in increased fatigue, reduced participation in therapy and exercise or socializing, more likely to miss school, increased infections, and also preventable nutrition deficiencies. So when I was thinking about how to discuss nutrition tips for Mito, because it is such a broad area, I thought that if we went through what I would typically do in an assessment and then how we would brainstorm strategies for different scenarios so that we can cover a number of different topics. So at a dietitian appointment, we are doing a nutrition assessment as well as growth. So we'll look at all the vitamins and minerals, protein and energy and fat and fluid, as well as the growth of the child. But it's much more than that. So we know that feeding is really complex, and understanding the way children and adolescents eat can be challenging. So we know that interest and skills and capacity for feeding are affected by a large number of things. And in an assessment, we'd be wanting to understand the medical background, if there are any recurrent illnesses or gut health concerns. We want to know a child's feeding history, because where they have been and their journey can often impact where they are now. And the more we can understand that, the more we can work out what supports might suit them best. We look at the mealtime environment. So everything that's going on around eating impacts eating and feeding. So we need to really understand how we can support that. And we'll look at development and safety of swallowing skills. And that is done usually with a multidisciplinary team. So we need to look at our occupational therapist, our physiotherapist or speech therapist quite often to support some of these things around eating, nutrition and feeding. So a goal that we commonly set for nutrition tips for Mito is looking at growth and improving weight gain. So as part of the assessment, we would do a growth and physical assessment, and that looks different for everyone. So you can see in the picture, we have some wheelchair scales that we might be using, or we might be using standing scales or baby scales. We might be measuring height through a stadiometer, so a child standing up, or we might be looking at segmental lengths, so measuring from their knee to their foot as a way to assess how they're going with their nutrition status and growth. We'll have a look at plotting measurements over time on a growth chart. And you can see on this particular chart, we've been looking at these red dots. So this is the weight and where it used to track along the line. And then over time, it's slowly decreased in the percentiles of where it was tracking. So what we want to do is set some goals around how we can improve it to come back up to the line that it was previously on before. We also want it to be in proportion to where length has been. So we'd set some goals around improving energy intake in this situation. So some children do need added protein and energy to assist with their weight gain and growth. So we use a little phrase called making every bite count. So for some children, that may mean adding high energy additions to food. And I've given an example here with scrambled eggs. So if we have 2 scrambled eggs, it's going to be around 160 calories. But if we are able to add some grated cheese, maybe some margarine, then we've automatically boosted the calories to 355. And we don't ask parents to work out any of this sort of stuff, but it's just to illustrate how those 2 scrambled eggs, we've boosted the energy within them without asking the child to then go and have extra eggs or extra food on top of that. And it's optimizing the bites that they're already taking. We look at using all full fat dairy products, so your milk, yogurt, and cheese. We'd be thinking about adding sauces or gravies, dressings, and all these things are really individual to the child's preferences and working out what's going to be best to boost their energy. Other ideas would be always serving lower energy foods like fruit and vegetables with some extra additions like yogurt or custard or oil. We might drizzle extra oil on pasta or use nut butters, things like that. We'd aim to establish a regular eating pattern. So in busy life or with activities that kids might be going to or therapies they might be going to, it's really common to be rushing from one place to another and we may miss out on snacks. So we really try and work out some practical ways to implement that within the child's lifestyle so that they're having 2 to 3 snacks a day as well as their main meals. We quite often need to choose foods that need less chewing. And are easier and quick to eat. So that may be based on the child's feeding, chewing and swallowing skills or where they're up to with their development or just needing to eat something quickly because they're rushing around. We'd avoid lots of fluid at meal times because this can be filling for kids, being mindful that they still need to drink so they're hydrated. When we're talking about eating out of the home or rushing around, we try and brainstorm strategies to take ready-to-eat high-energy snacks so that we're on the go. And that may be things like tubs of yogurt or cheese and crackers, biscuits with spread, trail mix, energy bars. The lists are endless. But we'll also give recipe ideas if needed. So, for example, we've got some muffins there, but these are not just your standard muffin. We can think about ways to add extra energy to them and adjusting recipes for that purpose. In some cases, we may consider oral nutrition supplements. So these are like special drinks that give protein and energy as well as vitamin and minerals often to help top up what nutrients might be required. And we may also look at tube feeds if needed. Quite often we will see children with gastrointestinal discomfort, so tummy troubles, and we'll often set goals around improving gastrointestinal symptoms. So an example of that is constipation. So we know that if a child's constipated, they're going to be less likely to want to eat and have less appetite. They may be less likely to tolerate tube feeds if that's happening for them and more likely to have reflux. So we want to make sure that a child is not constipated. But there is a large variation in what is considered normal bowel habits. So for something to be considered constipation, it has to include 2 of these criteria for a month or 2. So we want less, well, we don't want this, but less than 2 stools a week is considered constipation. Withholding or incomplete evacuation, painful or hard bowel motions, large diameter stools, a presence of large fecal mass in the rectum, and in toilet-trained children, we might also see some soiling issues. So when we're doing an assessment, we'll often ask lots of questions around poo and the consistency of the stool. So for example, in this situation, we might look for around a type 3 or a type 4 to be considered a normal bowel motion. So for some, I quite often hear, they got runny poo, so it can't be constipation. But in reality, what that can mean is that a child can still be constipated and there's just a blockage that the bowel motion is running past. So it's really important to have that thorough assessment and understand if constipation is a factor. And then we brainstorm strategies on how to treat it. So for some children, it's really behavioral, particularly for young kids, because, they're busy playing or they might be doing other things or be a bit scared of going on the toilet. There can be so many factors that lead to withholding and constipation issues. So we'll be talking around those sorts of strategies, maybe implementing some or suggesting some toilet sits after having a meal. Trying to teach them to listen to their body's cues, and we might get support from an occupational therapist to help us with that. We look at the position of the child sitting on the toilet. So having our knees and hips at like a 90 angle and the knees a bit higher than where the hips are can be helpful. So having a stool or some sort of foot position that supports that can help. And we'd be investigating barriers around going to the toilet, for example, access at school. Dietary modification itself is not usually an adequate treatment. So if a child wasn't eating enough fiber or not drinking enough fluid, then we can certainly look at ways to meet their requirements for that. But adding extra on top doesn't fix constipation. And in some situations, extra fiber can actually make the problem worse. So usually we look at some sort of laxative. So we'd want to be choosing our laxatives carefully, and we like to use things that are not going to create dependence. So your osmotic or lubricant laxatives, the osmotic ones, they draw water into the bowel and help the stool to pass through without creating dependence. So they can be used safely long term. And what we know is, or the most common thing that I see is the child will go on a product like Osmolax or Movicol, one of these laxatives, and then their bowels will start moving. So naturally, the treatment will then be stopped because we think, okay, the problem's fixed. But what we know is that the bowel, when it goes through constipation, it stretches and it takes time for that to return to its usual shape. So if we stop the laxative treatment too soon, then the constipation returns and we get like a cycle of this treat repeat, which we want to avoid. So usually it comes down to having a regular dose of a laxative long term to allow that bowel health to recover. And sometimes we'll adjust the dose. So if bowel motions are becoming too frequent, then we might reduce the dose down a little bit, but still keep some of it in there. Quite often we'll also see concerns like reflux, which can have nausea or reduced appetite associated with it. And quite often then with kids, they really want to avoid this pain and associate pain with feeding and swallowing. So that can cause them to not eat even if they are hungry. So it affects their relationship with food and can affect how much energy and nutrients they get in. So we definitely need to support that. And what's happening with reflux, you can see our stomach here, we've got our contents, and it's when the acid comes up into the esophageal area. So we want to try and avoid that from happening. And for dietary management, we'd be looking at strategies like small frequent meals, trying to separate liquid from food, so that we're not really filling up that tummy in one big go. We look at positioning, so remaining sort of upright for say half an hour after feeds, rather than laying flat. For older people, then it might be avoiding triggers like caffeine or chili. Sometimes really fatty, deep fried food can be triggering for some people. And if a child is tube fed, then we might need to adjust the rate or the volume of their feeds to help manage the reflux. We also know that treating constipation is really important to support reflux management. And in a lot of situations, we may need some medication, and that's guided by the paediatrician. Other goals we might set would be around ensuring food is appropriate for swallow or feeding skills. So a question that I'm asking when we're doing an assessment is about any signs of aspiration. So what aspiration is when the food or fluid is going down into the airway rather than the esophagus or the food pipe. So if we're seeing signs of coughing or choking when eating, if there's really lengthy feeding times, or if a child's really unsettled during their feed or refusing, if they're having unexplained frequent chest infections, or a reliance on feeding when they're partly asleep or poor weight gain, all these things can be signs that there may be something else that we need to address or assess. So often we'll need to refer to a paediatric speech pathologist that focuses on feeding and swallow. And they can provide us guidance around safe textures and consistencies or appropriateness of foods. And then as dietitians, and we would optimize the nutrition to meet the guide that the speech pathologist has provided. So in some situations, that may be modifying the food texture or looking at thickened fluids to support that swallow safety. Other goals might be around optimizing nutrition to reduce fatigue, so supporting our energy levels. So what we really want to do is maintain a regular energy supply. And again, that comes down to our 3 meals and 3 snacks quite often for kids. So avoiding skipping meals and snacks and brainstorming ways to have those things ready on the go, as we've already spoken about. We want to make sure there's a balance of protein, fat, and energy going in, so our energy nutrients. In some situations, we might look at the types of carbohydrate. So what we do know is that if someone is having a really refined carbohydrate diet, so things like soft drinks, chips, white bread, then we can get a spike in our blood sugar levels and a drop, and it feels like an energy slump. So if we're able to adjust our carbohydrates to lower GI, then we're going to get a more sustained energy release. So that's things like whole grain breads and pastas rather than the more refined options. We may look at the timing of food around exercise or daily living and making sure that we've got enough fuel for what the child's trying to do. And we'd also be wondering about micronutrient adequacy. So we know that, for example, iron, if that is low, then that can make us feel more tired and fatigued. So that brings me to other goals that we may set around ensuring vitamins and minerals are adequate. So really common micronutrients where we might see low levels would be kids that may not eat enough iron-rich foods. So a lot of our really powerhouse sources of iron are things like meat and chicken. So they are often harder to chew. So we might need to look at adjusting the textures of these things because kids, they find it hard to chew a steak. So we might be looking at ways to introduce, say, more mincemeat textures, things that are going to be easier and quicker for them to eat, as well as looking at overall iron sources in the body, because there are fortified breakfast cereals and breads that can be swapped out, or we might need to look at supplements as well to support that. We know that calcium is really important for bone health, and same with vitamin D. They're interrelated in bone health. And so we want to make sure that we're getting enough calcium, particularly if the child is non-weight bearing, because there's usually a higher incidence of fractures. And we also want to make sure that we're getting enough sunlight, because vitamin D is from the sun, and it's quite hard to get enough vitamin D from food sources alone. So we look at the whole nutrition picture and all the vitamins and minerals, but they're just a few examples of what I might be screening for in an assessment. One way that we might look at that nutrition balance is by doing a food diary. So we ask families to record what the child eats or what their feeds might be for a few days, and then analyze that down to the micronutrient. And we don't always need to do this. We might look at the food groups just in general by asking about what they're eating, but it can be a way to work out if we need any additional supplements to support their nutrition. And then we translate all that technical stuff into food strategies. And so it's just to show you that even though it can sound quite complicated, that we'd be looking at really practical food tips. So independent of where the child is up to with their eating or feeding or the texture that they may be able to have, we'd be translating that into food to get the different food groups and nutrients in a way that the child is happy to accept. Quite often the mealtime environment plays a really large role in nutrition. So we often do set goals around a supportive mealtime environment. So really common factors that I see that impact eating, or what people tell me in the clinic, is parents will come in and say, I'm so stressed, meal times is really hard and I just don't enjoy it. And quite often then we might see prompting or encouragement, bribes, chasing kids around with the spoon, like anything that we can do to try and support the nutrition, is what families usually say that they're trying to do at home. And so this leads to a cycle. So we call it the worry cycle. But I like to try and explain it like a mealtime triangle for families. And so what I mean by that is, say the base of the triangle is like our family table or mealtime. And then the ideal mealtime environment is to have the child leaning into the meal and the parent or caregiver leaning into the meal. And what typically happens, for one reason or another, the child may lean out from that meal. And that may be for so many different reasons. It can be developmental, it can be, reflux or pain or independence. There's so many things that they may be leaning out. And so coming from a place of love, the caregiver leans in saying, come back to this meal table. And then the child leans out further. So a large part of our strategies is working out, okay, how can we reset this balance and the relationship with food and make feeding more joyful for the child and the caregiver? So we will look at strategies to support a positive feeding relationship. Where we can, we try and optimize the socialization at eating. So feeding should be pleasurable for parent and child, independent of whether the child is eating or tube feeding or a bit of both. We may look at strategies around the role of parent and caregiver, of caregiver and child at the table. So the division of responsibility explains those roles, and there are caveats to it. But what we like to consider is the parent being in charge of what foods are offered. And when I say that, we need to be a little bit considerate with where the child's up to. So making sure that there is a preferred food available for them in that decision-making process, but it doesn't mean that we have to go around and cater and cook to their every whim. We want the caregiver to decide when food will be offered and allowing time for the child to develop some appetite, and also where the food is offered. And it doesn't have to be sitting at the dining table. Sometimes it might be a floor picnic, or, it can vary so much. We're just trying to have a little bit of enjoyment. And then the child's role at meals is to decide how much to eat and have as many servings as they like. And it doesn't really matter what it is out of what the caregiver has offered. And they may choose not to eat. And in some situations, if we're concerned with growth, then there may be dietitian intervention required to support that process and relationship. Yeah, I like to include this just as an illustration of the steps that children take when they're learning to eat. And it is by no means a nice linear step like this. I think we think about it like jumping up and down and the different phases. But it's just to illustrate that any sort of interaction a child has with the food in a positive way is a step towards eating. So even if they're not actually eating it yet, if we're just having that supportive mealtime environment where they're around a food that they're still feeling comfortable around, then that is a step towards eating, even if it's touching or smelling. And we like to think about it in a way that's not coercing the child to do these things, but it's just to illustrate that, you know, these types of exposures are actually getting us towards eating the food, even though they might not be doing it. Often we'll talk a lot about the language at meal times. So some examples would be if a child is refusing their food, you don't have to eat it. That's okay. We try not to comment on what or how much the child has eaten and know that they'll progress at their own pace. And if they refuse, it's not that they don't like it. It's just maybe they're still learning to like it. And we just need to hold space for that. And any sort of pressure or bribes or rewards usually results in less intake of that food. Even though it might seem in the short term that they might have a bite of it, we know that long term, that's not setting up a sustainable relationship with that food. And often we'll say, okay, this is what we're having, and just leave it at that if the child's saying they don't want it. If a child has tried something new, then I like to try and phase out the phrase, did you like it? Because usually the knee-jerk reaction is no. So if we're wanting to open that conversation, being really conscious of no pressure, but if they've tried something and they're wanting to talk about it with you, then what did you think? An open question can be supportive in that. If they're pulling faces or scrunching up, it's just a little bit of reassurance. Like, it takes time. I'm still getting used to that. It's okay. And if they're saying yuck, then quite often we like to put a pause in that comment. So things like don't yuck my yum, or we're not rude to food are common phrases that I hear. But really we're just trying to sort of limit the conversations and pressure around food and talk about other things related to food. Because as I mentioned, pressure, bribes, and rewards, even praise can slow down the process. And praise is, you know, it's coming from a beautiful place. We just want to encourage our kids, and all the positive parenting stuff is praise, praise. But in reality, what we know for some kids, if they eat something and then we praise them for it, then that can also feel like pressure. And so they may think, oh, I was brave that time, but what if I don't feel brave next time? And they can retreat. So we just want to move that spotlight away from the child at meal times. And when a child feels pressured to eat more, they often end up eating less. So research shows us that when they're pushed to eat specific fruit and vegetables, then they tend to eat less of those as well. So we just want to keep offering preferred or safe foods as well as some unfamiliar foods at the mealtime. We want to eat together or feed together, talk in a calm, positive way about the child's day or positive interests instead of the food, and allow enough time to enjoy those meals together. Try mixing it up. So eating in other places like those floor picnics or in the backyard can be supportive of a novel mealtime environment and can improve eating. And do not encourage to try the food, but instead modeling. So eating a wide variety of foods yourself is setting a really good example for your child. And then what about tube feeding? So something that's really, really valuable is aiming to encourage the social side of eating, even if the food is coming from a feeding tube for a child. We really want to demedicalize it. And I like to sort of set some guidelines around that from the beginning. So things like placing a feeding tube behind a child and having them as part of the environment with social side of eating can be really supportive. And there's a lot we can do to support that. So if you would like any further services, please contact Nourish Paediatrics. There's my website, and we can support with a wide range of nutrition tips for children with Mito.